There we go. Now can you hear me?
Yes, thank you.
Here, I'll back up just a tiny bit. I wasn't sure how many, sorry about that. IHCCA is a 100% volunteer board, so anybody who wants to volunteer can volunteer for us. Our mission is to provide information for post-acute healthcare providers. And this is a perfect example today, having Dennis Kelly present some vital Idaho specific information. And we hope to have a few more of these special sessions as they come up. There's kind of 3 of us right now on the board. That's myself as the president. Catherine Jones she does a lot. She's a secretary, treasurer, and also the administrator. She does all of the website and handles all the emails for us. We're very thankful for her. And then Rick Bassett we have a pretty robust legislation and policy committee, and they meet once a month usually. They're on break during the summer months.
Kimberly,
yes,
this is Catherine. Make sure there's more than 3 of us on the board.
Well, of course, yes.
3 of us are the chair and basically the executive board.
The
but
executive
we have
board.
some wonderful board members that volunteer their time.
We do have some amazing volunteers. Thank you very much, and board members. So welcome to the special session of the Idaho Hospice Updates. This will bring you to Dennis Kelly. Let me just get it. Dennis Kelly is the Acute and Continuing Care Supervisor, Idaho Department of Health and Welfare Division of Licensing and Certification. Most of us know who he is. And with that, Dennis, I will stop sharing and give you the floor.
Thank you very much. Am I being heard okay?
Yeah, you are.
Okay, great. Thanks. First of all, I want to thank Kim and IHCCA for setting this up. IHCCA has been kind of a favorite of mine because it does have membership that it crosses the continuum of care, and as such I think we get an opportunity to talk about things that are pertinent and relevant to what's going on in our own communities within Idaho. Recently, IHCCA has been disseminating some articles specific to hospice and things that are taking place out there in the country. And in particular, I responded to Kim that, we've had some activity in Idaho. So what we're talking about today, hopefully will be of interest to you. It's not just things taking place nationally that we can point and say it's the other guys out there that we're concerned about, but things that are really taking place right here at home, and hopefully address some of the topics proactively before the questionable practices that we're going to be talking about become an after the fact recovery issue for us. As we go through some of these talking points, there undoubtedly be some surprises. I think that the activity does exist here in Idaho, but I encourage not just to be thinking about this is happening for the other guy, but look at your own practices and understand how some of these things may impact you. Kimberly says a lot of you know me because I've been around a while, getting older, and as a result of that, I have some historical perspective, and I thought we'd start with the historical perspective. Over time, there's always been warning shots. CMS has given us warning shots that have taken place before enhanced regulatory changes. And if you think back, for home health agencies, that's how OASIS came to be. There were warning shots on things that were happening in our communities that, well, we didn't pay attention to. So OASIS became a result of that. A good change, but none of this, it was because of things that were happening. Tightening of medical eligibility requirements in hospice, for example, adult failure to thrive in dementia, face-to-face encounters, all of these came as a result of sometimes we just weren't paying attention to some of the things that were being identified out there. Right now, I would say this is another one of those times where warning shots have gone unheeded, and thus increased regulatory oversight is going to be the result. A big part of the text of what I'm going to be talking about comes from an article that came out from in the CMS blog, and everybody's got access to that. So if you've had a chance to read any of the articles that Kimberly has sent out, or you're paying attention to some of the new stuff, some of this won't be a surprise to you. But as a result of some questionable practices out there, these are some of the changes that are taking place. CMS is pledging enhanced oversight of new hospice providers in several states, in particular, California, Nevada, Arizona, and Texas. But I do want to say, as we go through this, please understand that this enhanced oversight is not limited to CMS oversight, and it's not limited to those states, but those are some of the states that where some of this stuff has begun to really expand. I'll say this. Let me put it this way: if you think about a community, and in that particular community, there's gangs or something, right, that are going on in a particular area within a city, and law enforcement comes in and says, we're going to pay particular attention to the things that are going on in these particular neighborhoods. What happens? The criminal activity moves into other areas. And so with the enhanced oversight in California, Nevada, Tennessee, or Texas and Nevada, we're starting to see some of these activities move into Idaho and other states as well. As a result of some of these questionable practices, CMS has been conducting unannounced on-site visits to every Medicare enrolled hospice, making sure that each hospice is operational at the site listed on their enrollment form. Hospice has been visited through mid-August. They're reporting that they've made some 7,000 on-site visits to currently enrolled hospice programs. Through mid-August, 400 of these hospices are being considered for potential administrative actions depending upon their findings. Some agencies may be deactivated or revoked based upon the findings that they're having. So you may have people show up at your site unannounced. We're not here for survey necessarily, but we're here to, are you who you say you are, and doing the things? Are you operational where you are saying you are operational? I'll get into what we're going to be doing as a state agency, but right now I'm talking specifically what CMS is saying that they're doing or proposing to do. CMS is proposing they will be doing medical reviews before making payments on claims submitted by newly enrolled hospices. There are targeting those 4 states in particular. Specifically, this is what they're putting out in their news. And however, I would say, again, going back historically, when things happen in one area, we start to see them expand into other areas. So this is Dennis saying, heads up, look at yourself, look at the things that are going on in your agency, because it could be expanded upon. If any of you have ever been through ADR processes, heads up, things very likely you could be experiencing some of these things as well. CMS is proposing a 36-month rule for hospices, prohibiting the transfer of provider agreements and Medicare billing privileges, and the precedent for that is home health agencies. What does this mean? It means if you start an agency, the ability to sell that agency may not be able to happen if this proposal goes through for 36 months. There'd be a moratorium on being able to sell that. If you've been paying attention to the new rules for hospice, we've been expecting the special focus surveys to be taking place there during this past federal fiscal year. It didn't take place because some of these changes were initiated during COVID, and because of waivers and whatnot, some of these things have been delayed. But for the upcoming federal fiscal year, which starts October 1, we are expecting that there will be special focus hospices that are identified by CMS, and they give us, the state agency, kind of some marching orders, if you will, on based upon their algorithm, increased oversight of poor performing hospices with repeated cycles of serious health and safety deficiencies. We're still waiting to, and for transparency, we're still waiting for some of those assignments. So right now, I do not know who's going to be a special focus agency, but they will be coming. So be aware of that. They're proposing a review of hospice claims following an individual's first 90 days of hospice care. And they're very specific in the blog that they sent out on August 22nd, they published that. This is not going to be a pilot that is limited to Arizona, California, Nevada, and Texas. So, and this is, again, trying to identify what are some of the issues specifically with individual hospice or Medicare beneficiaries that are electing their hospice benefit, to solve things before they become a problem. They're also proposing to have authority to screen hospice certifying physicians to ensure that they are qualified to treat Medicare beneficiaries, including making sure that they have active licenses and do not have felony convictions. That may seem like a shock to some of you, that would be something that we would have to consider, but the reality is it's real, it's happening, and so the oversight is going to increase there as well. Proposing criminal background checks for owners upon Medicare enrollment. A lot of you are used to the MACs doing ADRs or the RAC audits or ZPIC audits over historically. Upcoming, we've got what they're calling the supplemental medical review contractor reviews, and they're identifying essentially 10 things, not limited to, but 10 things of note that if you're looking at what can I do in my own practice to tighten things up, what should I be looking at, I would recommend that you look seriously at these 10 items. The hospice certification of terminal illness, and that means initial and subsequent to cover the billing dates of service. What's a certifying or attending physician doing, including the oral and verbal certification and the physician's narrative? Do you have all those things there in a timely manner? Not going to, in this call, we won't have near enough time to talk about individual subtleties and nuances with each one of these, but as a bullet point, be looking at your CTIs, looking at your MARS, your medication administration records or infusion flow sheets documenting quantity administered of a dose, route, frequency, all of those things. Tighten up on your medical records. What's your plan of care saying that you need to do? What are the daily visits saying that is happening? And what is the review process on your MARS? Your physician's order for hospice. Is it existing? We're looking at, unfortunately, in many circumstances, the marketing goes, we're working backwards, and you're going out there and people are being identified as potentially eligible for the hospice benefit, and they may or may not be. But once you've got that individual targeted and are having conversations with them, is there a physician order for hospice prior to the initiation of care for that individual? Looking at your hospice initial and comprehensive assessments and your updated assessments covering all of your specified dates of service. If you've been through an ADR process, please note that they are generally looking for a calendar, July 1 to the end of July. Send us your medical record during that period of time, and they'll be looking for certain information for that probe. However, the things that we're talking about in these bullet points are things of note that could e essentially cause a technical issue, right? So is that face-to-face encounter done in a timely manner? No, it isn't. So even though they may have asked for your medical record for that individual for these particular times, they look at all these other contributing factors and they may say, no, we're going to deny these payments because of other issues other than what we were originally looking for. Hoping that it'll make sense to a lot of you who have been through the ADR process. It may not, if you haven't been through it, it may not make sense, but you can reach out to me after this down the road if things come up, and we can talk about it more in detail. When they look at a medical record, they're also going to be looking for your IDG notes. What's going on? What's the coordination of care that's taking place? Who's showing up for your IDG? Who's participating in your IDG? What's the coordination of care? And what's the evidence that there is follow-up to the things identified in your IDG meetings? What's the documentation that supports the beneficiary's need for the level and frequency of either home health or hospice services provided, including any changes during that review period? That is a very vague and broad statement, but essentially, if you think about the individual that we're providing care for, what is the documentation that supports, that says we're doing this for the right things for the right people at the right time, and this is how we document that, why we're doing what we're doing or why we're not doing. If there's something glaring that's not getting done, sometimes there may be a physician's order that says, don't address these issues because I'm addressing these over here, maybe with a cardiologist or something like that, but I want you taking care of these. So where's the documentation? The ABN and the NOM-NOC. So are you doing the advanced beneficiary notice of non-coverage or the notice of Medicare non-coverage at the right time? And this usually happens, I would encourage each and every one of you to look at your live discharges, whether they're from revocations or discharge for cause. What's happening? Are you providing all of the things that it says? And sometimes you need to look beyond the conditions of participation and look into your Medicare benefit policy manual. And that's where it's going to have all the things. If you're looking at a live discharge, what are the bullet points that you need to make sure that you're doing to ensure that you're doing that at the right time and that you're providing the Medicare beneficiary all of the information to make a seamless transition into whatever another next level of care may be. And then the catch-all, any other supporting documentation. There's no way that the conditions of participation can be so prescriptive to cover each and every opportunity that comes our way, each and every event. For those of you that I've had individual conversations with over the years, you've heard me say it over and over and over. Document, so that if we come in or it's an ADR or anything that somebody's looking into what happened, that I can see what your thinking process was. How did you get to that decision? Well, we met as an IDG. We discussed these things. We had a governing body meeting. Here's the minutes to that meeting, and it shows me how you arrived at those decisions. And that context can solve a lot of problems. It helps me get into that sliver of time, that moment when things were really in the heat of the moment, in the fray, and you were making those decisions. How did you get there? And sometimes for some of you, an event may occur, and it's like us that are doing survey. Many times we're looking backwards. Something bad happened, and we're looking back. How did that happen? These are the changes that we're making based upon what happened. That becomes part of your quality program and your QAPI environment. You're doing a root cause analysis. Those are invaluable in helping me and other entities that may be looking into your business to arrive at this is how they got there. Each and every agency has very unique communities, very unique uh, uh, people that you're seeing, and because of that, there's 100 ways to do things right. And so again, the state, CMS, we're not going to be so prescriptive that we say, there's only one way to get to the right place. There's many ways to get to the right place, but sometimes we need you to help guide us. This is how we got there, for it to make sense. So I want to switch gears for a moment and talk about some of the things that have been happening in Idaho specifically. We have had a number of new applications post-COVID. We have had a tremendous increase in changes of ownership, changes of information, and initial enrollment, particularly in home health, and even more significantly in the hospice arena. Looking at what CMS is giving us as these warning shots, as a state agency, we've decided to jump in and do some things proactively as well. Every one of you know that we don't have a licensure process in Idaho for hospices like we do for home health. As a result, there's some things that could easily get missed in that approval process. So the state agency still has a role in that approval process, even though the state doesn't have a licensure component. So as a result of having a plethora of new applicants and looking at that paperwork, we're going, are we confident that these people exist, that they're doing what they say that they're doing? Are they operational? When we get information from a new enrollment from the MAC, because somebody has gone into the PACO system and saying, hey, we're starting a new hospice and we're going to do it at this location, we're up and running, we're ready for survey. And we go out. So in the past roughly 8-9 months, we've had 15 new applications for hospice providers. The majority of those are in Boise, Idaho. Okay, let's do we feel that there is an access issue that would require that many new hospices in Idaho? Not so much. Our observations is that we've got people bumping into each other. Everybody's trying to go after that same group of people. So it just makes us go, And as a result, I have sent survey teams to do the same thing that CMS is saying that they're doing, and to go out there and say, is there a hospice in operation there? Do they have patients? Are they taking on patients? Do they have clinical staff? I would be shocked if I was on the listening side of this presentation, but I've been living it right now. Whereas out of the 15 that we have gone out and visited, 13 have been non-operational, no staff, no patients. 2 of these have actually had accreditation organization surveys for deemed status. And so it's a process right now it's kind of evolving, and we're trying to decide, okay, how do we need to approach this? So in Idaho, we are requiring and have required, this is not shocker news to anybody, that to come in as a new enrollee, that you have to go through an accreditation organization, obtain an initial survey for deemed status. So we've had some of these new folks that have done that. And then the next step would be for the state agency to review all of the documents that have been sent in, including that coming from the accreditation organization, and make a decision on whether we're recommending approval of certification or not, send that to the MAC, and then it goes through that final process. We have seen where it's gotten to the point where, yes, they have had an accreditation organization survey, they've obtained deemed status, and then my team goes out there and they're not in operation. Uh, Patients have been discharged and they're waiting to do something else with that agency at some point in the future. If they're not in operation when we come there, I am recommending disapproval of federal certification to CMS. And this is occurring. So in Idaho, once a new provider has come in, they've submitted all their proper paperwork, they have gone through an accreditation organization initial survey, they can expect not only a visit from CMS at some point to verify that they are in operation, but also from the state agency, because before I pull the trigger for sending my approval to the MAC, I need evidence that they really are doing what they say that they're doing.
Dennis,
Yes.
I have a question.
Yes.
So, do we need to wait for final approval from Medicare and issuance of the PTAN before we start seeing patients? Because we're kind of in a process right now where deemed status has been submitted. The state has approved and submit documentation back to Medicare, but we don't have a PTAN yet.
So in my world, in the past, I have when I've done startups, that's part of the risk of doing a startup. Part of the investment of doing a startup is that you're taking on patients, you're doing these patients without being able to bill until you have that survey that says you're good to go. Now, once that survey is done and you're good to go, historically you've been able to bill back dating to the date of that effective date. But until you get that CCN number and are able to bill, you're seeing patients without the benefit of having those checks come in. That's part of doing business. The risk is if you stop doing business and you're not in operation, I can't get it approved, right? I can't in good conscience, based upon what I'm seeing out there, go out there and recommend federal certification for something that's not in operation. Does that answer your question?
Yes, it does. Thank you so
Okay.
much.
You bet. And if any of you want to talk privately about your individual circumstances, please reach out to me afterwards, and we can talk about that. So our visit, on-site verification, we're not coming out on a survey. We're going to say the process is you've enrolled, you've taken on patients, you're not waiting for licensure to take on patients because there is no licensure in Idaho. So once you've submitted your application, we're going to go under the assumption you're taking on patients in anticipation of an accreditation survey. That accreditation survey takes place once we have the documentation that has been successful. We start our review and processing of that documentation, but you can expect an unannounced survey from us, an unannounced site visit from us to verify, yes, you are still taking on patients. Yes, you do have clinical staff. What our observations have been, they've kind of been all over the place, but we've come into entities that have successfully received a survey from an AO, and we come in a little bit after the fact, and they've discharged all the patients. They don't have any clinical staff, and again, individual circumstances are very different, but in one of these circumstances, it was a situation where, well, we didn't start it to run it, we started it to sell it. And okay, but you can't sell something that doesn't exist. That's in the state operations manual. If it doesn't exist, it's not an entity that you can sell. So we're expecting those things to continue. You will see patients, you will have clinical staff, you will be doing all the components that are a legitimate hospice, whether it's day one or year 5. You know, it's going to continue to be in operation. One of the other things that we're doing, and this is, I stole this from another state in an environment that I worked in years ago, and requiring a face-to-face provider engagement session here in our bureau offices with new providers and with the buyers. If it's a child, if it's a change of ownership, we're going to ask the buyers to come and visit with us, and there's multiple reasons for that. One, it allows us an opportunity for the legitimate providers to do that face-to-face introduction, for them to get to know the bureau, for us to be able to explain what are the resources, what can we do to help you be successful in your communities, what are some of the pitfalls that we're seeing, take you through our website, show you what the resources are so you can do a deeper dive onto things. But it also, because of the activity that we've had on suspicious activity and questionable providers in Idaho and in other states in our country, it gives us an opportunity to separate the wheat and the chaff, so to speak, and see who's going to show up. I had just anecdotally, I had a man fly in from Coeur d'Alene yesterday that's starting a new venture up north. He flew down. We spent a couple hours talking and going over things. He was thrilled with the opportunity to get to know us, because it's vague out there. It's this mystery. Who is this Dennis guy that answers the phone or returns these emails? What's the credibility? This helps increase the well, it increases the relationship. IHCCA, I love the A of IHCCA. It's the alliance, you know, and that, just by stating it, it's an alliance, means we're on the same page. We're trying to do the same thing. We feel very strongly that you as a provider and we as a state agency have very similar responsibilities for the safe and effective care of the people that come into our world. We need to do it right. And it's that whole thing with Medicare, you know, here's the check, but here's the rule book. You can't have one without the other. If you want to cash the check, you got to follow the rules. We also realize that because of people that are out there, that the bad actors that are causing problems for everybody, that it may slow down some of this process. We get that, but hopefully we're hoping that you're going to have the buy-in for these extra activities, because for the legitimate providers, we're seeking to protect you and what you do, that you're trying to do things legitimately out there in your communities and take care of these people. Yeah, you know, look at the gray. You know, I'm going to be one of these guys pretty soon. It's going to be on somebody's service, right? So we want to make sure that you're doing it right and that you're comfortable doing it right and not being influenced or negatively impacted in your communities by the poor actors out there that are out there making trouble. I mean, you just think about it. If we had 12 new hospices in the Treasure Valley open up right now and out there marketing, and if they're not doing it for the right reasons, like the rest of you are, what problem is that going to cause for you and cause for the Medicare beneficiaries as a whole? So on-site visits, after you've had your survey, that's something that we're going to be doing. CMS is going to be doing. We're going to be requiring that face-to-face provider engagement before I sign off and send it up. So everybody will get to know us before they start doing business, either as an initial or as a new buyer. I'm going to pause there. I get passionate about this because I've been doing hospice since before it was a Medicare benefit, and we've seen so many changes over the years, where Went back in the day when I started, we had brink of death referrals. If we had somebody last 5 days, we were shocked. And we saw that it was primarily cancer diagnoses. Now, over the years, we saw that pendulum start to swing. Yes, people die for other reasons. Yes, they don't have to be brink of death. But then we see that pendulum swing all the way over here to where we go in, and we've got half of somebody's census is in the 12th benefit period. That raises all sorts of questions in our mind for further deeper dive into what's really going on. Does it happen? Absolutely, it can happen. But to where it's half your census or more, I'll let you decide that for yourself. I can't make those individual decisions for you, but I can almost promise you and guarantee you that other people are going to be looking into your medical records to find out, are these things legitimate? I'm going to look in the chat, see if
there hasn't been anybody in the chat. If you have a question and you want to talk to Dennis later about it, please feel free to put it in the chat. So anybody have any questions at this point?
What Kim and I discussed is that there may be questions that may be beneficial for everybody. And if there are things that you put into the chat, then we can try and get some answers using regulatory language, or again, you can feel free to reach out to us here at the Bureau with specific questions about whatever's on your mind. And that goes for any time, not just for as a result of this, but hopefully those of you that have been through surveys over the past few years have a good understanding that we're not trying to put targets on your back. We're trying to protect the Medicare beneficiaries out there. And to do that, I really feel strongly we need to be on the same page, and we can get there. I believe that. Any questions, concerns, things that you've been seeing out there? If you've got concerns about things that you're seeing out there, reach out.
Dennis,
Yes.
this is Cindy Lee. Hey, how are you?
I'm doing good, Cindy Lee.
Good. Hey, I have a question. We're in some facilities, and the care is just, their caregiver shortage is phenomenal in this community, and I'm not sure what the answers are. Do you guys have an idea of how we're going to fix some of those issues? I mean, some of our patients just look terrible, and the staff are trying. I mean, it's not like you have a bunch that say, oh yeah, we don't bathe on Thursdays, and we don't. No, they're saying we just had 3 quit yesterday, and we can't seem to get enough staff to help us. Could you address that just a little bit so that we can maybe help them? We try to increase our visits and stuff, but man, it is a real problem.
It's a horrible, and we're having problems here, even at the Bureau. Maintaining the levels of staffing of qualified surveyors pre-COVID versus now, we're running at about 50% of what we were doing, prior to COVID, because of mostly we lost people because of retirement. I mean, COVID was a great time if you were getting close to retirement to pull that trigger. We're seeing that in every provider type, Cindy Lee. We're seeing that, and not just in Idaho, across the nation. It's one of the big topic points that we have. My caution is just being extremely careful. Regardless of staffing issues and the difficulty, you're still required to meet the regulatory compliance and take care of the patients. We have had some providers in multiple different provider types that have had to terminate their agencies, their facilities. And I'm talking hospitals are struggling, ASCs are struggling, dialysis centers are struggling, home health, hospice, rural health clinics. It's across the board. But we still have to take care of the patients. We can't sacrifice some of the quality of care because there's a staffing shortage. We've had some instances where we have had to cite agencies and facilities for using people to do tasks that are outside their scope of practice, to try and stretch what they're doing out there. Not a good way to do it. Not an acceptable way to do it. I don't have the answer, Cindy Lee. I think it's a huge problem that's being addressed nationally. Being creative. Even before the shortage, when we would go out and survey, it would track. One of the things that I would watch for is if an agency or a facility was having consistent citations in a particular area. It's like, okay, what are the causative factors? And I'd look at their voluntary turnover rate and it'd be sky high. I'd look at another agency that we go into that was consistently good, very few, if any, citations. And I said, okay, what's going on there? And they had a very low voluntary turnover rate. They kept their people engaged for a significant period of time, and they did better as a general rule. We hit COVID and everything started being the shell game, people moving all over the place, and we still see a lot of movement. We see incredible sign-on bonuses. We see people hiring from out of state. I don't know. There's just a lot of people trying a lot of different things, but I think where individually as an agency where you're going to be more successful is if you can maintain a low turnover rate, keep your people happy, then generally I think you're going to be more successful. The recruiting will still be quite a challenge.
Dennis, there's a couple things in the chat. One is yes, the copy of the recording will be on our website, but it looks like Dr. Gallinger had a question. In addition to facilities being short-staffed, many skilled nursing facilities are not allowing hospice in the building. Studies are clear quality of care is better with hospice. Seems hospice is EOL. Should be a quality metric for for facilities. Sorry, any potential solutions on the horizon?
The point is very well taken, and I could not agree more that end of life care is a specialty. The relationship between hospice and SNFs has been an issue since way before it was even part of the Medicare benefit, and it has continued. Interestingly enough, I talked about that pendulum swinging. There was a season where SNFs were allowing hospices to come in, but we didn't have the plethora of hospices. We had a significant relationship of a hospice and a SNF, and they would bond, they would communicate, they would do the things that were necessary. But as the numbers of hospices really took off and it became profitable for a hospice to say, hey, I can take care of 5 patients in this SNF as opposed to all that windshield time and a lower productivity rate going out into the rural communities where there is a significant need for hospice care as well. Then a SNF winds up with 5 hospices all wanting to do business, taking care of the same patients in that same facility. And it's an example where without the relationships, the competition gets messy and they're stepping on each other, and the communication that should be taking place to ensure good quality end-of-life care is being provided in that SNF, then it gets anemic and they start working against each other, and the loser is the patient. And so the quality metric is to work on is a good relationship between the hospice and the people at the SNF. What can we help provide? What can we help communicate so that it's about the patient? And I can remember back in the day running a team where we would go into these facilities, and I would watch nurses or any other clinician go in, and they wanted everything at the SNF to stop. and pay attention to me because I'm here and I've got a lot of other patients to see, pay attention to what I need right now. And the reality is we're walking into somebody else's house. They've got regs that they need to comply with. I need to be the expert at understanding the SNF regs and the pressures that they have. And if I work with you instead of against you or independently, much better outcomes for the patient. And that's what the SNF's after. That's what the hospice is after. And that's what the patient and the family wants. So relationships and working together. I don't think regulatory components come involved because people aren't doing it well. My contention is that I absolutely believe if you form the right kinds of relationships and solve your own problems with that SNF, it will work so much better than having to be told how to do it. The right things will come about.
If I could keep going on that question. So
Sure.
I discharge people from the hospital often as a palliative provider at Boise St. Alphonsus, and we identify a place for the patient to live at a SNF, and we try and care plan for hospice to be on board because they're at end of life. And the SNF, and I'm not saying just for my hospice, I'm saying any hospice, we just got to get this person that care. And the SNF's response is, yeah, we'll take the patient, but no hospices are allowed in our building. And so I don't think it's a poor relationship component. What I'm hearing is they're incentivized by the insurance company to get better reimbursement if hospice is not on board. And so it seems as though there's a situation in which the money is greater to provide poor care.
Yeah, and I don't think there's a simple answer because there's too many reasons that could be precipitating that particular SNF making that particular decision. And I would question how they got there. Is it a financial incentive for them, or is it, once burned, I don't want to be burned again? Or was I allowing hospices to come in before and things were happening that we got cited by the group that's coming in and surveying to the SNF regulations? I think there's a lot of things that can play into it. So rather than a carte blanche wide swath, I really would go back to individual SNFs. What's the causative factor? What's going on there? There's too many moving parts to say there's a one answer to that, but I totally agree. The loser is going to be the patient if we can't work out how to provide care for that individual together. Anything else in the chat, Kim?
There's nothing else in the chat.
Okay.
Thank you for that presentation. It was really, really amazing. And I know we're all really busy. I believe everybody has Dennis's contact information. It will be listed on the website. And again, the recording will be on the website if you have any questions or concerns. And we might have another special session here coming up. It depends on how it goes. But I appreciate the comments that were made. I agree a little bit about the SNFs, Dr. Gallinger, I agree with that. So thank you guys.
Kimberly, this is Catherine. Once the video is posted on our website and our YouTube channel, I will send out an email to our subscribers.
Awesome.
So
Thank you.
You'll know it's there with a link to the video.
Perfect. Thank you. Thank you, everybody. Have a
Thank you.
good rest of the week. Thank you, Dennis.
Thank you, Kim. Thank you, Dennis.